All right, I think we'll go ahead and get started while a few more folks are joining. So good morning, everybody. Welcome to the TB 101 series. Today we're going to be covering treatment of tuberculosis disease. But before I introduce our speaker, I just wanted to give an opportunity for anybody to ask any questions from last week's session. Related to lab testing and interpretation of test results within the clinical context. So if you have any questions, feel free to unmute and ask your question, or you can put them in the chat as well. So I'll just allow like a couple of minutes for that. And just a reminder too that the slides and the handouts from last week are posted on the TB 101 page on our website. I know that it was very technical and probably a little bit higher than a TB 101 level. So also if you have any feedback for, what might be more useful moving forward as we continue to offer these sessions, feel free to send any feedback to myself or to Shweta. Hey, Patty.
Hey, Anita. I'm going to put the drug card in the chat if anybody, this is a really good resource. I love these cards. So there are drug treatment cards that I keep on me all the time.
Thanks, Patty. And yeah, you guys can order these from our website and we ship those free of charge. All right, if there are no questions, I'll go ahead and introduce our speaker for today's session. Dr. Ami Petrawala is the medical director here at the Lattimore practice, which is the clinical arm of the Global Tuberculosis Institute. She is also an associate professor of medicine at Rutgers, New Jersey Medical School and program director for the Pulmonary and Critical Care Fellowship here at the medical school. So Dr. Petrawala has done some global and domestic work in TB. She also she does the ICU service and is she's trained in pulmonary medicine. And so she sees patients at our clinic here at the Global TB Institute and is also very much involved in medical education at the medical school. So I'll turn it over to Dr. Petrawala and she's going to cover treatment of TB disease. Thanks, Ami.
Hi, thank you, Anita. Good to see a lot of familiar names out there. Let me share my slides. Okay, does that look right?
Yes, that looks great.
Okay, so we're going to talk about treatment of TB disease, and I think the slides should probably take about a half an hour, 35 minutes or so, and then I have a couple of cases, no formal polling or anything like that, but we can just read through the chat. You can enter things into the chat. Okay. So this is sort of, the overall overarching statement I think that we keep in mind whenever we are caring for patients with tuberculosis, especially patients who have tuberculosis disease or active infections. Really the responsibility for treatment is assigned to the healthcare team, both the physicians, nurses, as well as the case management team. And while the patient is a big part of that and their family as well, really we have to put the onus on our team to make sure that the patient and their family are appropriately cared for. And so having said that, we really put a lot of emphasis on individual case management with directly observed therapy, again, all to really benefit the patient and their family, get them better, reduce the impact on public health, and get them back to a regular life. And so case management is really a person or a patient-centered strategy. And I think often in this setting, we think about the whole family or household. Case managers are really responsible for making sure that patients understand what tuberculosis is and what the treatment entails, ensuring that therapy is completed. And of course, confirming that all the contacts to that individual are evaluated and hopefully treated as well. Directly observed therapy, which comes in many different flavors and forms these days, and I think has become something that is really much more patient and person centered, is a really vital part of case management. And really the point is to help patients complete treatment. And then, I'll touch a little bit on how treatment regimens can be individualized. I think when most people think about TB treatment, they think about, the same regimen we've been using for a long time, but certainly we can tailor the treatment, and there are newer regimens that you may all be using very soon, if not already. So again, the specific objectives of TB treatment is curing the individual patient, and of course, reducing transmission and breaking that cycle of transmission as quickly as possible. So we want to cure the patient, minimize morbidity and mortality, reduce transmission to other people, especially vulnerable people, and prevent the development of drug resistance during treatment. And most of the information in these slides is from the treatment guidelines for pan-susceptible TB disease that were last published in 2016. So the specific goals of this multi-drug treatment regimen that we use is to rapidly kill the bacteria in the first few weeks and render that person less infectious or non-infectious, and to also alleviate a lot of their symptoms. To use all of these medications together, really to reduce the potential for these bacteria to develop drug resistance. And then, if that were all, we might be able to complete treatment in 2 months, right? Because most people by 2 to 3 months are, their infectious burden has decreased, they feel better, but we continue treatment for 6 months, sometimes for 9 months. And the real reason is the third bullet point here, that we have to prevent relapse. And we have to sterilize, in this case, we're primarily talking about the lung. We really have to sterilize the lung. And that, with the medications that we've had available, really takes 6 months to get at those organisms that are not the actively dividing, growing organisms, but what we call, or what you might hear of as called persisting organisms or persisters. And so there are particular drugs in the regimen that work better against those organisms, but it really takes time. And so if we don't continue treatment out to the required duration, the patient may feel better, and they may feel better for quite some time, but their likelihood of relapse later on is much higher. And so we really want to achieve a cure with the smallest likelihood of relapse possible. And we really aim for, less than 5% relapse. And even that sounds like a lot. So oftentimes in TB disease, we are starting empiric therapy without necessarily having all of the data. As I'm sure you've heard or known, while there have been improvements in how quickly we can get TB diagnostics done with PCR tests and rapid tests and things like that, culture can still take several weeks, out to 6 weeks or 8 weeks, depending on what kind of cultures are being done. And, even if you don't talk about cultures, you talk about smear and PCR. If you think about some other infections that we treat, let's say in the hospital, we have rapid tests for almost everything, right? You get COVID antigen tests back in a few minutes, you get rapid strep tests back, quickly in an office setting. And so even when you're talking about days, not even talking about weeks to months, we're talking about days, that is a long time in the world of infectious diseases. And so TB is sort of unique or special in that way, that we really, do need to use our clinical judgment, our assessment of risk factors, and make as educated of a guess as possible to decide if people warrant treatment before we have all of the answers. And I think that's especially true in people who are, presenting to the hospital, who are sick, who are maybe, coughing up blood, or are losing a lot of weight, or people who are otherwise immunosuppressed. And I think that this requires a lot of education, both for the healthcare team, but also for the patients and their families, because, you can't say, people will ask you, are you 100% sure this is what I have? And I'm going to start on all these medications that might make me more sick. And so I think that, we have to figure out how we can sort of easily explain this, and make sure that patients and their families understand that we're not just sort of unnecessarily throwing a lot of medications on. And of course, we all hope that we're going to get a slam dunk diagnosis. We're going to see AFB on the sputum smear. We're going to get a PCR back in a few hours and, have a positive MTB test. And that all makes it much easier to go ahead and treat. But we know that that's not the case. Even in the best case scenario, your AFB smear may be positive, only 50 to 60% of the time, maybe 70% of the time in some studies I've seen. But of course, a negative smear does not rule out TB disease. And in some cases, a negative TB culture also does not rule out TB disease. There are a number of cases that we treat that are what we call clinical cases. The suspicion for TB was high, the imaging and the symptoms fit. We started the person on TB treatment, the cultures never became positive, but their symptoms improved and their X-ray improved. And so those are what we call culture negative or clinical cases. And that, at least in the US, according to our data, happens about 15 to 20% of the time. And then tuberculin skin testing or interferon gamma release assays are supportive, but are really not helpful if they're negative. So certainly if your IGRA, your TST is positive and somebody has symptoms and an X-ray fitting with TB disease, that can sort of help people feel comfortable that yes, this is the right diagnosis. But up to a quarter of the time that IGRA or skin test may be negative, even in people who later become culture positive for MTB. And this is, I think, one of the misconceptions or myths I see most frequently out there. People, I think, automatically assume that a blood test means that, we have the answer. And they really put a lot of stock in that IGRA. And unfortunately, in the setting of somebody who is sick with active TB, that blood test can be negative. And we've seen that many times. So this is a sort of a chart that I pulled from those TB guidelines that kind of summarizes risk factors, lab findings, X-ray findings, the clinical status of the patient, as well as balancing all of that with public health. And the more features you have that sort of are on the left-hand side of the chart, that would favor treatment initiation empirically, meaning before you necessarily have data confirming that this is TB disease. And the more things you have pushing you towards the right might favor delayed treatment or no treatment. And so, you can look through this, but it is probably a lot of the things that you would anticipate. So if you have an alternate diagnosis, if the findings are atypical, not commonly seen with tuberculosis, or if you actually have microbiology results that go against it being tuberculosis, then you're going to focus on treating something else in that situation. If the person is very stable, they're home, they're not sick, they live alone, again, those may be features that allow you to wait a little bit to get more information before you start this multi-drug treatment. And sort of the reverse on the other side, somebody's very sick, they have a lot of symptoms, they're in the hospital. A lot of times, we see people with extrapulmonary disease who are very, very ill. If there's a concern for TB meningitis, those are generally times we don't want to wait. We can't really wait for our diagnostics. So there's a lot of shift in this table, I think, in the last few years. And so I think it's, important to know what drugs are in our first line regimens, and those are the ones in the first column. A lot of the, sort of crossing over of drugs from one column to another column has to do with the fluoroquinolones, so levofloxacin and moxifloxacin. I'm sure many of you have heard about a relatively new 4-month regimen for pan-susceptible TB disease. And there are some areas and jurisdictions that have started using this shorter course 4-month regimen. And so that regimen includes moxifloxacin and rifapentine in place of rifampin, and then isoniazid and pyrazinamide as well. So those are the 4 drugs in that regimen. I'm happy to talk about that more if people have questions. But I would say there's, we still have our standard, 4-month regimen with isoniazid, ethambutol, rifampin, and pyrazinamide. But there's, some swapping around in these charts. So why do we have to use so many medications? Why can't we just give 1 or 2 or 3? Well, part of the reason is that each of these drugs has different features, different attributes that make them sort of work together in a cooperative way. As I mentioned, the standard of care is this 4-drug regimen given in a weight-based fashion. And the idea is that upfront in the first few weeks in the initial phase or the intensive phase, you really want to kill those actively multiplying bacteria. These are the bacteria that are making people sick, that are making them infectious to other people. Isoniazid in particular is very good and has a lot of early bactericidal activity. And so that's one of its, main roles in the treatment regimen. We want to improve symptoms. We want to prevent mortality, prevent death. We want to prevent transmission to other people. And at the same time, we want to prevent emergence of resistance. And when you have cavities in the lung and, millions and millions of organisms, there is ongoing spontaneous mutations happening in those bacteria. And so if you don't have enough quality drugs in the mix, you're going to promote resistance to emerge and select for resistance. And so some of the drugs like isoniazid and also our fluoroquinolones are really good at killing those actively multiplying bacteria. And then some of our other drugs like rifampin are particularly good at targeting those persisters, or those organisms that are kind of slow and lazy, but they're still there, and they will cause relapse. And so these drugs like rifampin, also giving these drugs for the longer duration, are what really end up helping you cure the disease and preventing relapse later on. Ethambutol is really in the regimen until you can verify that this is pan-susceptible disease. So it's sort of there to protect the other drugs from acquired drug resistance. And then pyrazinamide is kind of interesting. It works best in an acidic environment, which is in those, those big necrotic cavities of the lung. And so its role is really to help kill organisms in that acidic cavitary environment. And then older studies have shown that if you include pyrazinamide in the first 2 months of the drug regimen, again, in that intensive phase, that you can actually shorten treatment from 9 months to 6 months. And so this is the 4-drug regimen that has really brought us down to 6 months of treatment. And this is just kind of summarizing a lot of what I just mentioned. Ethambutol, once you find out, the bacteria is pan-susceptible, can be stopped. Pyrazinamide, we really want to continue for the full intensive phase of the first 2 months. And then it can be stopped. And then the continuation phase would be isoniazid and rifampin. So going into a little bit more detail with each phase of treatment, in the initial phase, again, we're talking about those actively dividing, actively replicating organisms, and really, preventing drug resistance. And also the intensive phase or the initial phase will help kind of determine what happens with the rest of the regimen. So if for some reason somebody is unable to tolerate pyrazinamide in the first 2 months of their treatment, the guidelines will tell you to extend treatment out to 9 months. And pyrazinamide being the drug that tends to cause the most hepatotoxicity, that can certainly happen where someone is just not able to tolerate pyrazinamide. And then I think we talked mostly about these points here, and including all 4 of those drugs. And then in the continuation phase, we are now talking about either 4 extra months. That's largely what we target. So a total of 6 months of treatment with INH and rifampin. Occasionally, it is recommended that you extend this phase or the continuation phase to 7 months, which is then a total of 9 months of treatment. And so one case would be, let's say there's pyrazinamide resistance, or you're unable to use pyrazinamide because of hepatotoxicity or some other intolerance. Then the recommendation would be to make the continuation phase 7 months instead of 4 months. There are other situations, if people have a lot of risk factors for relapse, that we may extend treatment in those patients as well. The one that I think is most commonly used or in the guidelines and that we talk about a lot is if somebody has a culture that remains positive after finishing their intensive phase. So they finish 2 months of treatment, you get the 2-month culture, and that culture returns positive for MTB, and they had cavitary disease, extensive disease on their X-ray. Those are people that we worry that they just had such a high burden of disease. They're taking a little bit longer to clear their cultures, that we would think about extending treatment to 9 months in those people, even if they had tolerated pyrazinamide early on. And then treatment completion is equally important. It really depends not just on how many months of treatment or how many weeks of treatment the patient received, but really how many doses of medicine they took in a specific period of time. So this is really where case management is very, very important to keep keep up to date with the patient, whether they're taking their medications regularly, are they on directly observed therapy. DOT is helpful, but it's helpful only if we keep up with keep up with how the patients are doing. If we're assessing their DOT, on a every other month basis, then by the time you recognize that there's an issue, it may be too late. And so really we need to keep on top of patients and make sure that they're taking their medications regularly. As mentioned, most people can be treated for drug susceptible TB with a 6-month regimen. Occasionally, we might extend this out to 9 months. And I think, really exciting that the newest regimen is this 4-month rifapentine moxifloxacin containing regimen that is being used in certain areas and in certain patient populations as well. And again, we can go more into detail with that. I think there are some logistical challenges that states and jurisdictions are really kind of aggressively looking at how we can make those logistical issues go away so that we can actually use this regimen. And Patty, feel free, or Anita, feel free to stop me if there are questions. So kind of moving on to monitoring, right? We care for these individuals for a long period of time. Medications, certainly, even if they don't have side effects that are limiting in that we have to stop the medications, almost every person has some sort of, not feeling perfect when they're taking these medications. And so patients need to be educated. They need to know when they should call and when they should sort of bump up their concerns. And I think, the more we tell patients up front about what to expect without necessarily saying, yes, on June 25th, you'll be done with your treatment, because that has its own issues. But, sort of making sure they understand that it really does take this long to cure you of tuberculosis and to prevent this from happening again and from you requiring treatment again, what tools we're going to use to ensure adherence and why we're using them really to help you with this sort of difficult journey, how we're going to monitor for adverse reactions, and how we're going to monitor treatment response. And, there's variability and individualization in these plans. And so I think we have to balance it, right? There are times where you can be too prescriptive and say, we're going to get, you're going to be done with treatment on X date, and people really stick to that, right? Like someone told me 6 months and I would be done. But nobody told me that if I couldn't tolerate pyrazinamide, I might need 9 months of treatment. So, I think it's important to give all this information, but at the same time, be clear that there can be things that will make us have to tailor the regimen or individualize the regimen. And sometimes comparing things to other conditions, if you have hypertension or if you have diabetes and this isn't working, these medications aren't working for you, we might have to switch to something else. And so maybe comparing to other things that people may be more familiar with. This table is also from the same treatment guidelines, and I think is just really helpful to kind of summarize what we're actually going to do before we start treatment and then during the treatment time period as well. So as far as at baseline, obviously we're going to have sputum smears and cultures and drug susceptibility testing. We will have imaging at baseline as well. You want to know what the baseline patient's weight is, what their symptoms are. And then, for people who will be on ethambutol, which is part of the standard regimen, we want to do a vision assessment at baseline. That includes visual acuity. We can use a Snellen chart, that's sort of the most common thing, and then to do color discrimination as well. at baseline. And these are all things that can be done in the office. And then for adults, at least, baseline laboratory testing is recommended: liver function tests, a platelet count, renal function, and an HIV test if they haven't had one. And then additional testing like hepatitis screening and things like that, maybe based on those baseline labs, or if you know that they have other medical history. And then that's all at baseline. And then during treatment, there's sort of the minimum that we should do when we're monitoring patients, and then, you know, what seems needed or would help you sort of assess how the patient is doing. So in terms of ongoing monitoring, everybody should have a monthly clinical evaluation to make sure that they're adherent to the medications, answer any questions, identify if they're having any side effects, or if there's something else going on with their health. We also, if they're still on ethambutol, we want to at least ask if they're having any visual disturbances or changes, and then do a monthly color discrimination test. Now, most patients are only on ethambutol for the first 2 months of their treatment, and so you're probably not going to continue to do that every single month after that. Extrapulmonary TB, I haven't, you know, we're really not talking about too much today. I think that is, you know, there is no guideline for how to monitor people with extrapulmonary TB. It really depends on what site is involved and how sick the patient is. Most of the time with extrapulmonary TB, you can't just repeat the micro tests, right? The sputum test or what have you. And so you may be looking at monitoring symptoms, monitoring imaging, and that kind of thing. So I think most of this we touched on in terms of evaluating response to treatment. And you know, this is a good reminder that some people feel better very, very quickly. And again, it's a good time to reiterate, yes, you feel better. We're so happy that you feel better, but we don't want you to relapse and you have to keep taking your medication. Most people will culture convert by 3 months of treatment. So more than 90% should have culture conversion by the 3rd month of treatment. Data from a couple of years ago in the US, about 70% of people convert by that 2-month mark. And if the conversion, meaning their culture is going from positive to negative, seems slow, like you're in that 2nd or 3rd month, then that person should really be evaluated to understand, you know, why is the conversion slow? Is it because they had extensive disease to begin with? Is there an issue with adherence or absorption? And do we need to consider longer treatment? And then, you know, as part of this response to treatment, we are also responsible for making decisions about return to home, return to work. This is really very much individualized based on who else is in the household, what the work environment is like, how infectious we think this person was at baseline, and how quickly they're improving. In terms of sort of understanding how we can relate the microbiology results to what we should expect during the treatment phase. Clearly, if people had positive sputum cultures when they started treatment, we want to obtain monthly specimens until we have at least 2 that are negative, 2 consecutive negative specimens. I tend to get monthly sputums when the person comes to the office because they're there, and I like to keep track of it, and I like having a little bit more data. But really, the requirement is that you should have at least 2 consecutive negative sputum cultures, and then you don't really need to get more sputum cultures done. And that's for pan-susceptible disease. If they have drug-resistant disease, then we do get monthly monthly cultures. I think that a 2-month X-ray is very helpful to see if people are radiologically improving as their microbiology improves. Remember, you get the 2-month sputum culture, you obtain it, but you're not going to get results for maybe a month after that. So getting an X-ray at that 2-month mark can really be helpful. But getting that 2-month X-ray is not essential per the guidelines. If somebody had negative cultures at the start of treatment, then that X-ray becomes very, very important, because aside from symptoms, it's really your only way of knowing if the person is responding to the treatment that you have them on. So if they were baseline culture negative, this is culture negative TB or a clinical case of TB, then the 2-month culture, or the 2-month X-ray is important. If somebody has not converted their culture from positive to negative after 3 months of treatment, then we have additional work to do. We want to ensure that they're taking their medications, they're adherent, they're absorbing them, that they're not taking some medicines one day and other medicines the next day. We want to assess for drug-resistant disease. So if somebody is culture positive after 3 months of treatment, then you would want to repeat the drug susceptibilities. So we get them at baseline, but if somebody remains culture positive, then you would want to repeat their drug susceptibility as well, and make sure that they haven't acquired drug resistance along the way. And then positive cultures after 4 months of treatment is considered a treatment failure. And again, you're going to assess that patient. Why did they fail? Is it an adherence issue? Is it a drug resistant issue? What else might be going on? And that's somebody who may need, a real change in their treatment regimen, or at the very least, a longer treatment regimen. So this is, I think, summarizing a lot of what was in that chart. Again, for culture positive TB, you want monthly cultures until you have 2 that are negative, and that includes the 2-month culture. Consider repeating the X-ray at 2 months, but you don't have to per the guidelines. If the initial culture is negative, then the 2-month chest X-ray is something that we really rely on. So in terms of hospital discharge planning, which I'm sure many of you are very involved in, this is something that, we try and start the process very, very early on. We don't, want the person to be 3 weeks into treatment and then starting to think about discharge planning. So the minute that the person is diagnosed or TB is suspected, or we're starting TB drugs, we want to start thinking about discharge planning. And this would include, the inpatient case managers and healthcare team and discharge planners, as well as the case managers and healthcare team in the TB clinic as well, right? So all of this has to be done jointly. A home assessment is very important in this situation. We want to make sure that we're not putting other people in the household at risk, and that we're identifying everybody who is in the household potentially exposed and needs to be tested. And this is especially, regarding vulnerable household members like very young children. And then I'm just putting this back up there to show you sort of everything that is grayed out is technically, dependent on what the initial baseline testing was, or is, quote unquote optional. Everything else is sort of required. So again, sputum, smear, and culture at baseline, and then at least 2 consecutive negative cultures. If this month 2 is still a positive culture, or let's say month 1 was negative, but month 2 is positive, then we should continue getting sputum cultures. If your 3-month culture is still positive, then we should repeat the drug susceptibility testing. Chest x-ray at 2 months is not necessarily required, but I think it's helpful. End of treatment chest x-ray is also optional, but again, I find it very helpful. A lot of our patients with pulmonary TB are left with abnormal x-rays. So they may have improved over the course of the 6 months, but their x-ray is not normal at the end of treatment. They have scar, they have atelectasis, they may have nodules and things like that. And I think that getting the end of treatment x-ray helps prevent future unnecessary workup. So when that patient represents for something else and their x-ray is abnormal, they may not have to go through the whole workup for active TB again, which I'm sure some of you have seen, multiple times. If we have that end of treatment x-ray, so we know that really, they had this end of treatment x-ray and now 2 years later, their x-ray really looks the same. Weight is something that we follow, with every visit, and is a very good indication if people are clinically responding. We talked about symptoms and tracking adherence. Vision testing really is important in the first couple months when people are on ethambutol. And as far as lab monitoring, so everything is really dependent on what you find at baseline. So if somebody has liver disease, then you're probably going to be following their liver function tests, maybe monthly, maybe more than monthly. But if they're normal and they don't have any symptoms, you don't necessarily have to get monthly labs. And I certainly don't get monthly labs if somebody is otherwise healthy and has no physical exam findings of jaundice or any GI complaints. So some of the things that, lead to drug resistance or are more associated with drug resistance is obviously coming from a place where there's a higher incidence of drug-resistant TB, exposure to somebody who either relapsed or failed treatment, and people who've had a previous episode of TB treatment. So I've had a few patients over the years who, were treated 5 or 10 years ago for TB disease, and now they're, they have a new episode of active TB, and those are people that are at higher risk of drug resistance, whether they had drug resistance all along, or it was acquired along the way. And you may have patients who have drug susceptible disease at baseline, but then they were put on an inadequate treatment regimen, or they weren't on directly observed therapy, or they weren't, adherent to their treatment, or rarely they're malabsorbing, not absorbing the medications. Those people may acquire drug resistance while they are on treatment for TB disease. Completion of therapy, as I alluded to earlier, is really defined by the number of doses taken within a specified time frame, and not just the amount of time. So if somebody is prescribed a 6-month regimen and they're taking their medications every day, then they should have at least 182 doses. So that's 26 weeks of treatment of isoniazid and rifampin, and their intensive phase, they should have had 56 doses of pyrazinamide. If they're taking some places, some clinics give 5-day-a-week treatment or only count 5 days a week, and don't count the Saturday, Sunday, weekend doses. In that case, it should be at least 130 doses of isoniazid and rifampin. And all of these tables are also in the treatment guidelines, and nobody needs to memorize them. I think you just look at those treatment cards that Patty was that put in the chat, or the guidelines. So if somebody has an interruption of their treatment regimen, whether they were not adherent, or they had some sort of side effect and the medications need to be held for a specific amount of time, you don't always need to go back to the beginning. So generally speaking, if somebody is able to complete their intensive phase doses within 3 months, that is usually acceptable. And if somebody is able to complete their complete their continuation phase doses, so the latter 4 months of isoniazid and rifampin within 6 months, then that is generally acceptable. Now, it may depend on how the patient's doing, if their cultures are, converting to negative or not, and all those other factors. But if somebody's remains culture negative and is otherwise doing well, in theory, if they took 2 extra months to finish their last 4 months of treatment, that would be okay. And then there are some charts that I think are helpful. Every clinic or jurisdiction may have their own way of doing things, but I think that some of these algorithms are really helpful. And we do worry much more about interruptions in the first 2 months of treatment. So if treatment was interrupted in the intensive phase, for a significant amount of time, then you may be, recommending that person start their treatment regimen over again. And again, because this is the phase where people have a higher burden of infection, they're potentially infectious to other people, and this is sort of the, critical part of their treatment. So this is one of those algorithms I was talking about. This is specifically for the first 2 months or the intensive phase of treatment. So in this algorithm, if treatment is interrupted for more than 14 days, then the recommendation would be to start over from the beginning. If treatment was interrupted for less than 14 days and you can still complete treatment within 3 months, that first 2 months of intensive phase within 3 months, then you don't have to start over. You can just continue treatment until all the doses are done, and then you move on to the continuation phase. And then if somebody made it through their intensive phase with no interruptions, but now they're in their continuation phase, those last 4 months, and they have an interruption in their treatment, then we really look at the percentage of doses. So if they finished more than 80% of their doses already, then they may not need any more treatment, actually. It really depends on whether their sputum smear was negative or positive at baseline. If they were smear negative at baseline, you may not need to give them any more treatment at that point. If their smear was positive, then you should finish the total number of doses that was initially intended. And then the reverse, if somebody hasn't yet finished 80% of their doses, then you go back to whether they can finish the continuation phase within 6 months of treatment. So if they were interrupted for more than 3 months, then you really should start over from the beginning, which is really unfortunate. But I think these kinds of algorithms, if you work your way down, it really helps and makes sense. And obviously, the shorter amount of interruption or no interruption is really the ideal thing. So, just to summarize, we really want to center case management around the patient and the household. We really don't want to make it punitive in any way. We want to encourage, incentivize as much as possible completing treatment. The standard treatment is the multi-drug 6-month regimen, although, more and more we are hearing that people are using the 4-month rifapentine moxi treatment regimen. We didn't talk about it today, but there are situations where you may need additional help or guidance, certainly in pregnancy, in people who have concomitant HIV infection, or people who have baseline kidney or liver disease. So I think that's my last slide. I'm happy to take any questions, or we can do a little case discussion.
If anybody has any questions, can you please put them in the chat? I do just have one question, since this is kind of a problem, and we had a call the other day with this region that we're still having this kind of ongoing INH issue, which I guess hopefully it's easing up a little bit, but we kind of had to switch to, or some people had to switch to alternate regimens without INH. Maybe you can just talk a little bit about that regimen, since it's something that we're kind of recommending.
Right.
And there's another question in the chat after that.
Okay. So yeah, so good, very good point. I think that the isoniazid shortage has been something really challenging to deal with for so many reasons. I think the recommendation for treating people with INH resistant tuberculosis is to treat with rifampin, pyrazinamide, ethambutol, and to add a fluoroquinolone like levofloxacin or moxifloxacin. And that's really the regimen that we've been turning to when we can't guarantee that somebody can get isoniazid for their entire course of treatment. The treatment success is something that, probably needs to be looked at, but certainly in people who have INH resistant TB, adding the fluoroquinolone improves their outcome. And so I would, if you're treating without isoniazid, I would not just treat with rifampin, PZA, and ethambutol. I would add the fluoroquinolone. Now, I know that people have been running into issues with fluoroquinolone acquisition as well. I think especially moxifloxacin. So that's its whole other challenge. And, in your spare time, you can always join an advocacy effort to try and understand why these drug shortages keep happening and seem to impact TB more than some other diseases.
Yeah, I agree. There's another question in the chat. Can you please comment on drug-drug interaction between anticoagulants and rifamycins, and when you would use rifabutin instead of rifampin to reduce DDI?
Yeah, that is a very, very challenging issue. So rifampin will metabolize, rifampin will really metabolize your anticoagulants excessively. We see that, with warfarin, often you have to double or triple the warfarin dose, and even then it might not be adequate. So if somebody's on warfarin, we usually switch to rifabutin in that situation. But even with rifabutin, you need to watch the INR very, very carefully, and you often need to increase the warfarin dose. Now, kind of the bigger issue these days are the non-warfarin anticoagulants, like the direct thrombin inhibitors and the factor Xa inhibitors, that really, the beauty of those medications is that you don't monitor them with weekly INRs. Unfortunately, rifampin also interferes with all of those, what we call DOACs or NOACs as well. Rifabutin may be okay with some of them, but I think this is a situation where you really need sort of expert guidance, either from a pharmacist who really understands the drug-drug interactions, or, we're happy to help at the COE as well through consultation. So yeah, rifabutin might be necessary, but even then, if you were to look at the package inserts for these medications, it will tell you not to use rifabutin, even with the DOACs. So there is no easy answer. I will also plug, and maybe Anita, you can put it in the chat, the rifamycin drug interaction guide that was recently created between GTBI and the Curry Center in California. I find it really, really helpful to look at that.
We have a couple more good questions. With an alternative treatment, losing INH, do you still DC PZA at 40 doses, or is it still 4 drugs for the entire treatment?
So I have done it both ways. If the patient has really extensive disease and is tolerating the pyrazinamide, then I will continue it for the full 6 months. if they have less advanced disease or there's some issue with them taking the pyrazinamide for longer, then it can be stopped at 2 months. But to me, it depends sort of on how extensive their disease is.
Yeah, I guess every case is just so unique. So it's a lot of this stuff is case by case, I imagine.
Yeah.
Can you elaborate on the challenges with the new 4-month regimen?
So we actually haven't implemented it yet. And Patty, I don't know, you can speak to whether other places in New Jersey have implemented it. The challenges are, one, with drug acquisition. So rifapentine remains in short supply, and as it has for many years. And yes, we're told it's supposed to get better, but no, it hasn't gotten better yet. And now we're facing moxifloxacin shortages as well. I think not as universal as with isoniazid, but certainly that's a concern. The other sort of implementation concerns are that one, you really want to know that they are fluoroquinolone susceptible, early on in their treatment phase. And unless you are somewhere where you can get rapid fluoroquinolone susceptibility testing done, that can be a barrier. And then the other issue is that, at least in the study that was done on this 4-month regimen, people were excluded from the study if they'd already received a standard regimen for a certain amount of time. And so ideally, we want to start people on the 4-month regimen relatively early, but a lot of times we don't have rifapentine, they're still in the hospital, we don't have our susceptibilities back. And so I think we'll learn from the people that are doing it. So at least in our region, I think in New York City, they've had a number of people on the 4-month regimen, and as time goes on, we'll sort of learn, what their challenges were and how they sort of implemented this. And Patty, I don't know, is anybody routinely doing 4 months in New Jersey yet?
No one is. Again, one of the barriers was the fluoroquinolone testing. I know CDC does it now because of the INH shortage. I don't know if they would do it for the 4-month regimen. Our lab problem with the GeneXpert cartridge for fluoroquinolones, it's not FDA approved. So our lab is working on, we'd love to get that in there. So that's one of our biggest barriers. And then the rifapentine, the way it's packaged, you need like 40 boxes, which takes up a lot of space. And again, the shortages. But we have a few more questions. Let's see. How do co-infections such as TB, HIV, co-infection impact treatment decisions and patient outcomes?
Okay. I just stopped sharing so I could see it also. How do co-infections such as TB, HIV impact treatment? Oh, yeah. Well, I think there are multiple issues. So if somebody, let's say, is diagnosed at the same time with active TB and HIV, typically, unless their HIV is very, very advanced, we are usually upfront focusing on TB treatment, and then later on starting their HIV treatment, and that has a lot to do with the potential for paradoxical reactions, where there may be sort of clinical worsening in the first few weeks when somebody is started on HIV treatment. And then the second issue is really the pill burden. So, it's so many pills. Now, a lot of the HIV treatment regimens now are like 1 pill a day, or, not the handful of pills that people needed to take in the past. But still, it's a lot of medications all at once to be starting. And there are drug-drug interactions to be worried about. So if the co-infection is diagnosed at the same time, then we usually focus on TB treatment first, and then their HIV treatment in a few weeks, unless their HIV is very advanced, in which case it's recommended that you start both treatments at the same time. If somebody has HIV and they're stable on a regimen, then the main thing, I wouldn't stop their regimen for HIV. We would start TB treatment, but we would have to consider the drug-drug interaction, mostly of the rifamycin, with their HIV regimen. And again, that is very highly individualized. There are great resources out there through the NIH website to look at drug-drug interactions between the different HIV regimens and whether you need to be on rifampin or rifabutin in that setting. And occasionally we do change the HIV treatment regimen, but we really try not to if somebody is stable on their regimen.
Can you treat with rifampin, EMB, PZA if patient is INH resistant or INH is not available and cannot tolerate fluoroquinolones?
You can, and in the previous set of guidelines, if I remember correctly, that was, that was considered okay. But there has been a reasonable amount of good data to suggest that the outcome is not as good in that situation without the fluoroquinolone. But yes, if they absolutely cannot tolerate the fluoroquinolone, whether you add other medications, there's really no guidance for that, and there's probably no data for that, whether you add linezolid or something else, or just treat with the 3 drugs. And that, in that setting, you might think about extending the treatment as well, especially if they have extensive disease.
Yeah, I know 100 years ago when I started, that's how we treated because fluoroquinolones weren't as popular in TB as they are now.
Right.
And
And again, I think in that situation, it is important to know that they're fluoroquinolone susceptible. Unfortunately, or fortunately, fluoroquinolones are used for lots of other things outside of tuberculosis. And I have had a few patients who either for tolerance or resistance reasons, they end up they are resistant to fluoroquinolones, even though, we had never used it for their TB before, but they're resistant because they got fluoroquinolones for quote unquote pneumonia or UTIs or something else.
Here's another question about dosing. Regarding dosing of INH and rifampin by weight, since for rifampin, for example, is available in 300 and 150 milligrams and INH 300 and 100, how do you dose as close to their weight but not underdose?
So for rifampin, the 10 milligram per kilogram dosing, I think, we all accept that is probably underdosing people. And more recent studies have looked at much higher doses of 15 to 20 milligrams per kilogram of rifampin. So, yes, while we still use 10 milligrams per kilogram and most adults are going to get 600 milligrams of rifampin, if somebody is between doses, if you have a 45 kilogram person and technically they should get 400 or 450 and you just can't do it with the pills you have available, I would always overdose as opposed to underdose. So I would always pick the higher dosing range than the lower one, especially because we know rifampin, the 10 milligram per kilogram is probably too low anyways. And most people are going to tolerate this okay. And for isoniazid, I guess I haven't had as many issues with dosing. But again, I would always sort of err on 50 milligrams higher than 50 milligrams lower.
Yeah, and it does come in liquid. The INH does come in liquid if you had to go that route, except for it's a lot of liquid, but.
And it tends to cause some diarrhea.
Yeah.
And so, I guess I would probably go there less often than, if I had to give a slightly higher dose than their weight. I would be okay with that, and we would just monitor those patients a little bit more carefully. Maybe I would get liver function tests more frequently. The other thing is that most people, if they're really that small, they tend to gain weight with treatment. As they get better, they gain weight, their appetite increases. And so the other thing to watch out for is that as they gain weight, you're not underdosing them later on. And it's not unusual to have people gain, 10, 15, 20% of their body weight. And that might put them in a different band of dosing.
Thank you. Anybody else have any further questions could put them in the chat. I just wanted to bring something up about, because, we're always about the weeks and the doses, and nurses go crazy about making sure they get enough doses. So when we talk 6 months, they say 26 weeks. And then when they say extended, this just came up like Wednesday in one of the clinics, and it's actually in the guidelines in the little tiny fine print, but then they say 7 months. But when they talk about the 7 months, they're actually talking about 31 weeks. So when you're trying to calculate your doses, you have to calculate it as the 7 months as 31 weeks if you want to be absolutely like on point with the guidelines. So that was our discussion, because we were like, how did we come up with 195 doses for the 9 months? But anyway, I just put that in as a sidebar, because when you read those guidelines, which I do, and I have highlighted all over the place, read the fine print too, because there's a lot of good stuff in there. Anybody else have any questions? I know we have till about 11:15. I don't know if there's anything else you wanted to cover, or if we want to end it here. I didn't know if you had a case study or anything like that we could do in that amount of time.
Yeah, it might take longer than that, but I can give another minute for questions. And then somebody had asked about the apixaban, rifamycin drug interactions. I just want to make sure we get that resource to you.
Yeah, if we don't get it in the chat, we can make sure that it gets emailed out to everybody as well, and with the other resources. And I think there is also the evaluation in the chat. If everybody could please fill out the evaluation, because we really do appreciate your feedback on how this went and anything you might look forward to seeing in the future. And I'm getting a lot of thank you and great classes. So with that, Dr. Petrawala, I will say thank you. A great presentation as always. And everybody else, have a great weekend. We will be back here next Friday, same time. And also next Friday after this, we will be having the NTNC will be having a webinar on the lab resources for public health nurses. All right,
Thank you.
Have a great weekend.
Bye-bye. Thanks, everyone.